Good morning, everyone. I think we'll go ahead and get started. This morning's speaker is Danielle Bullock. She is a third-year fellow in pediatric rheumatology. Her topic will reflect some of the research that she has done and for which she just won a Pediatric Rheumatology Research Award from the American College of Rheumatology's Rheumatology Research Foundation. She'll be presenting some of the work in this talk and will be presenting at the American College of Rheumatology Scientific Meeting in November in Washington, D.C. I hope you will find this not just about rheumatology, but relevant to your world as well. Thank you, Dr. Bullock.
Thank you, Dr. Bay, for the kind introduction. I'm just going to say a little bit more about my background because I think it provides some important context about why I ended up in pediatric rheumatology and why I will be talking about access to care today. So I went to college at DePauw University, which is a small college in Indiana, and majored in English literature there. And as I entered medical school at Indiana University, I really struggled with the amount of memorization that was required. And my strength, I think, was in thinking through problems, not in memorizing things. I obviously figured this out. I wouldn't be standing up here. But what I learned as I transitioned from those first couple years of medical school into the third and fourth more clinical years is that medicine is really about a story. And it's our job to put the pieces of that story together. So I came to the University of Minnesota for residency, swearing I would never move anywhere colder than Indiana. But it was really the global health program that brought me here. And I honestly did not anticipate becoming a pediatric rheumatologist, yet somehow as I learned the stories of patients with rheumatic diseases and kind of saw how that fit in with my interest in serving under-resourced patients and families, it really made sense for me to pursue this field, a field where there's a shortage of providers and geography plays a huge role in accessing care, as I'll show you today. So it's taken me some time to kind of understand how my interests and strengths could fit or intersect with the needs of our patients. But I think fellowship has really given me the opportunity to choose which interests I want to pursue. And I've enjoyed how this has unfolded so far and am excited about what's to come. As a part of my fellowship, I'm also completing a master's in public health. And this additional degree has really helped me connect my excitement for individual patient care with kind of the larger story or larger context which affects care. And I think this will come through in what I talk about today. So I hope that what I present reflects what I have learned along my journey and what I've learned from the fantastic people in my division. And the story I tell today will focus on pediatric rheumatology. But as with any story, I hope that you can find your place in it. So I have no financial disclosures and will not discuss the off-label use of anything. I just wanted to include the thanks here up front because the work that I've been doing and these interests that I have are certainly not done on my own, and the people in my division and the Explorer Clinic, the biostatistician I've worked with, my scholarship oversight committee, and the patients and families that I've worked with have all been instrumental in making this possible. So thank you up front. So by the end of this talk, I want people to be able to recognize the wide range of factors affecting health and describe how these might intersect with the care that we provide, be able to identify the 5 dimensions of access to care, and be able to discuss what resources might be used in identifying practical and acceptable access solutions. So as I'm discussing these things, I'll be moving from kind of a broad context to a more narrow scope. So I'll start by presenting general ideas around access to care, and then I'll give you some specific examples of how we've wrestled with these questions in our division. And my hope is that these specific examples will allow us to understand the broad principles and then generate conversation and perhaps even collaboration around these issues. So as a division, we're still in the process of exploring these ideas. We've not yet arrived, but hopefully sharing parts of our journey will be meaningful. So I don't want to be overly cheesy or simple, but take a moment just to think, why did you go into medicine? And why pediatrics? So I think different from this guy, it was probably not for the money. And I think most of us, if we think about this, would give some version of, I want to help people. You know, there's a lot of benefits to the career that we do, but at the end of the day, I think we care about people and we want to help them. So we obviously can't measure every aspect of how what we're doing affects people, yet there are some objective measures or outcomes which tell us how our patients are doing, or in other words, whether or not we're helping them. Some of these are what are called clinical outcomes. Some of these you may be more familiar with than others depending on what you do on a day-to-day basis. And then there's also an increasing attention on patient-reported outcomes like pain or quality of life. So what are the things that contribute to these outcomes and affect how our patients do? Does this depend just on what we're doing for them? You know, the direct patient care that we provide, the diagnoses we give, the treatments we recommend, these certainly affect health, but these are only one part of why a patient does or does not do well. And while many of us went into medicine to provide this direct patient care, I think it's imperative that we have an understanding of the bigger picture that's affecting outcomes. We're treating a person, but that person lives in a context. And this context has often been referred to as the social determinants of health, and this is an area that's been receiving a lot of attention recently. So this is just one model of health. There are many of them out there, but I think this helps us put into context or kind of acknowledge that health is complex. And as medical professionals, you know, we can't possibly be expected to understand or even address all these factors, and I'm not saying that we should, but I think it's important that we recognize that the patients that we care for are living in a larger story than this small slice that we're seeing, and we need to recognize that these factors work together, not in isolation. So today I'll be talking about access to care, which I think still falls within this kind of health services slice. What's interesting, though, is that I think access is very much at the intersection of health services and some of these other factors. So how to practically apply all this, I think, can sometimes feel a little bit elusive, and I hope that the examples I give you today will illustrate how we can plan care which takes into account more than just the clinical features of a disease. I also just want to mention that nationally there's increasing attention on how our patients are doing and on outcomes. And as a part of the Affordable Care Act, the Department of Health and Human Services was required to adopt what's called the National Quality Strategy. And this is called the Triple Aim as well. And you can see the three components of it are better care, improved health, and lower costs. So better care is making care more accessible, safe, and patient-centered, or improving the quality of care. Improving health has to do with addressing environmental, social, or behavioral components of health, and then lowering costs is making care more affordable. And so similar to what I pointed out in the diagram on the previous slide, these are interrelated. They play on one another, and it's important that we remember that the factors which are part of this improved health component, these environmental, social, behavioral factors, are linked to our ability to provide better care. And as I also mentioned on the previous slide, we may not be always directly involved with these factors or someone's community or the social network that they have, but I think we can recognize how these sort of things might create barriers to care, and being aware of these barriers can then help us plan better care, or care which is more accessible, safe, and patient-centered. So today I'll focus, like I said, on access to care, and it's not to ignore the other issues or other components of this, but there's just simply not enough time to cover them all. So the first question is, where do you start? Access to care is a very broad topic. If you Google this, you get 1.5 billion hits. So I started by reading those all. No. When I entered fellowship, I knew that there was a shortage of pediatric rheumatologists, and I wanted to learn more about what could be done to address this concern. And so I started by just gathering information. What does it mean to access care? What does this look like for pediatric rheumatology specifically? So again, the end goal of this is to find effective solutions to access gaps. But in order to do this, you need to understand what those gaps are and why they're happening. So what I learned as I started to look into this is that access is very complex, as with many other things. This is a model of access which was first published in 1981 and has 5 dimensions, all of them starting with A's, so I think it's kind of easy to remember. But you have availability, accessibility, accommodation, affordability, and acceptability. And if you just have one of these, that does not guarantee access. So care may be available, but if it's not accessible or affordable, you may not get care. There's been a lot of attention on affordability, obviously an important part of this, but just having something be affordable does not mean that you will get the care that you need. And so for rheumatology, we know that there's not enough supply, or that the availability is low, and that there are concerns about how accessible this care is. So most pediatric rheumatologists work at large academic centers, and this leaves large geographic areas without anybody. And there's people who have referred to kind of these two, the availability and accessibility part, together as spatial accessibility. So as I entered fellowship, this idea that pediatric rheumatology care is not very available or accessible seemed to be a commonly known fact. But my question was, well, how do we know this? What information do we have? And there's actually a lot of resources out there. These are the ones that I've found useful, and they'll show up in the slides that I show from here on out. But I just want to point out these are not all specific to pediatric rheumatology, but there's information about other subspecialties, so I'd encourage you to take a look and find out what the situation is for what you're doing. There's a lot of really good information out there. So this is information that was put out by the Arthritis Foundation a little over a year ago, and it looks at how many pediatric rheumatologists are in different states. And you can see from Minnesota, we have more than 4, but the neighboring states of the Dakotas, Montana, Wyoming, have none. And so, this shortage of providers has been an easy target when we're talking about discussing barriers to pediatric rheumatology care. And I think what's challenging, though, is what the solution should be. So is the solution simply getting more people? And, yes, that's part of it, but that takes time. I like this map a little bit better. It's a little bit older, from 2004, but I think it visually kind of captures the situation a little bit better. It's because it's broken down by county. So you can see there's Minneapolis, this is Rochester. Some of these don't show up as well, but there's some people in Nebraska, Denver, Colorado. But there's this whole kind of huge section of land here where there's nobody. And so again, I think, what's the solution to this poor geographic distribution of providers? Is it just more people? How do you convince those people to go to these places? There's some historical evidence that increasing the number of pediatric subspecialists does not necessarily mean that they will be more geographically spread out. People tend to go kind of to the same places, and so we need to think about this question. I think this kind of further drives home the point that for many specialties, a provider is more than 50 miles or 100 miles. 50 is the first column there, and 100 the second. That providers are far away. For pediatric rheumatology, we see that 35% are more than 50 miles and 18% more than 100. Pediatric sports medicine and neurodevelopmental are worse even than we are. Another way of looking at this would be by the average kind of population in that area. So where are the people who are under 18? Where are they living? If you think about a place like North Dakota, it's a huge area, but it's not very dense. And so this gives us an idea of the average miles to a provider based on where people are actually living. And for pediatric rheumatology, it's just shy of 60 miles. Again, neurodevelopmental and pediatric sports medicine are a little bit worse. So this is to show some of the work that's been done in thinking about this problem. Again, this data is a little bit older, but I included here the states which I think are relevant to kind of our situation. So we've looked at information suggesting there's a shortage of people, but how do we know how many people we need? Again, this varies depending on the specialty, but you can see here they have the state, the number. This is old, like I said, because they only say there's 4 in Minnesota, the population that's under 18, and then how many you would need to cover this population. That assumes this estimated number that the provider is fully clinical. And then they give the deficit. And the way they did this was there's some information that says you need 250,000 people under 18 to support your first pediatric rheumatologist, and then 200,000 for each additional pediatric rheumatologist. Those numbers differ by specialty, but that's how they figured this out. And again, this assumes people are fully clinical, and that would mean, based on how prevalent rheumatic diseases are, that each provider is seeing 1,000 patients a year. And really, that's not very realistic. Most providers see about 430. So these estimates are not even really close to what we need. It would be much more. I reran these numbers based on the current or 2014 population data, and if you combine all of these states together, it would be enough to support 8 to 9 pediatric rheumatologists. We currently have 8 in this state, but like I said, those are not all fully clinical. I think it's interesting too that if you look at like the Dakotas and Montana, that they're saying, there's not enough people in those states to support one person, but if you add those together, it's enough to support several. And so those patients are going somewhere. Many of them are coming here, but just to keep that in mind, that you have to still cover that area. So, as you've seen, there's good evidence that we lack pediatric rheumatologists and that these are not spread out very well. I didn't go into these other dimensions of accessing care, which are certainly important. But the question, though, is, what now? We need to be able to understand whether or not this is a problem for people. So what do primary doctors think about this? What do, parents or families or patients think about this? What alternatives can we use? And I think, too, what evidence do we have that this matters? Is it just a matter of convenience? And if it's just a matter of convenience for people, are we obligated to fix that? Are there, outcome differences depending on whether a pediatric patient is seeing an adult versus a pediatric provider? And, ultimately, if this does matter, what can we do to fix it? Maybe it's not just as easy as getting more people and convincing them to go somewhere where they might be practicing alone. Maybe there's other care models or other ways that we can provide care. And when we're doing this, how do we include what parents or families prioritize? So I just want to comment, there's kind of two ways of approaching these sorts of problems. There's a top-down approach or a bottom-up approach. I'll be talking mostly about approaches that would be more bottom-up. So top-down would be like there's a shortage of providers, we need more of them, we need to increase funding or incentives to recruit people to this field, and this usually involves policy-level decisions. Obviously important, but that takes time. Whereas these more bottom-up approach would be saying, okay, what are the local or institutional ways that we can look at the resources we have and how can we leverage those resources to meet our patients' needs? And those things that are done at a local level can certainly be used elsewhere or inform policy, but I think it's also important we take into consideration our specific patients' needs, and that may differ depending on where you're at. So the way that we've approached this so far in our division has been through these kind of three different projects, which I'm going to go through in a little more detail and highlight kind of how we're thinking about these things and what we've discovered along the way. So this is Dr. Carell from our division, the work that she did during fellowship, looking at barriers and alternatives to pediatric rheumatology referrals. This was a web-based survey of pediatricians in Minnesota and the Dakotas, and she had 93 respondents. 30% were at least 2 hours away, and 10% were more than 6 hours away, so capturing people from all over. And what she found was that primary care providers are sending patients to other subspecialists and to adult rheumatologists. So almost 90% said they had encountered a situation where they thought about sending a patient to pediatric rheumatology, but ultimately did not. And reasons for that, about 30% went to pediatric infectious disease, 20% to adult rheumatology, 12% to peds ortho, and about 34% managed the patient themselves. So why is this happening? Why are primary care doctors doing this, or what do they see as the problem? And one of the things that she found was that it does seem like travel time or distance is a barrier. And so 35% said that they had referred a pediatric patient to adult rheumatology. And the reason for that, one of the big reasons that they gave was that it was less travel time or distance. And then the other reason was the patient was an adolescent, and so they thought that was adequate to send them to an adult provider. So the work that Dr. Carell did was great, and there's been some other kind of work that has supported or gone along with what she found. This was a little bit after her study came out. The AAP published this updated workforce survey in July of 2015, and this is kind of what providers thought, how difficult was it to obtain a rheumatology appointment or consult in a timely manner. And you can see in Minnesota and North Dakota, it was between 36 to 49%, and in Montana and South Dakota, more than half. And so, why is this? I didn't really go into this a lot in this survey, but we can think about, is it that there's not enough availability or appointments, or is it distance? So there's lots of reasons why this could be, which they didn't go into in a whole lot of detail, but I think an interesting finding. So about a year later, in 2016, this article came out in the Journal of Pediatrics, which I think kind of further emphasizes these points. This was work that was done out of Pennsylvania, so not in Minnesota, but it was really interesting work where they looked at Medicaid claims of over 1 million patients, and they found several kind of notable things. But the one that I wanted to show you is this figure, which is asking a question essentially: does subspecialty utilization differ if you live further from a pediatric referral center? And so they compared patients who lived more than 90 minutes away versus those who lived less than 30 minutes away from a pediatric referral center, correcting for many other factors. And they're comparing those. If you fall along one of these lines, that means your relative risk is 1, or there's no difference. And so we can see that for pediatric rheumatology, if you live further away, you are less likely to go or be sent to a pediatric subspecialist, because you're to the left of this risk line here. You're more likely to be sent to an adult rheumatologist, and you're less likely to be sent to any subspecialist. And so I think, why does this matter? It goes back to this question. There's factors outside of health, such as where someone lives, that's affecting the health services that someone is receiving. And I think the question is, should this be the case? There's literature in several areas of medicine, not in pediatric rheumatology, but in many areas that shows that pediatric-specific care is less expensive, it's of greater quality, and so, yes, distance may be a barrier, but is it enough of a barrier to justify sending kids to other places? And in the long run, could this lead to worse outcomes and higher costs? And so the point they were making with this article is essentially, we need a better way of triaging people than geography. There may be some problems that adult providers can very well take care of, and we need to know how kids that go there do. Maybe there are some outcomes that it doesn't make a big difference, but maybe for some outcomes it is, and we need to understand that and have a system for how we can decide where people should go. So Dr. Carell's study, as well as these other two that I showed you, gave us insight into what providers are thinking and what they're doing. And we've learned that for providers, geography results in kids being sent elsewhere to other providers. So for my fellowship project, I wanted to learn what families think. There's been increasing attention on including the patient or the family voice in what we're doing. And we know that patient-centered care and research can lower cost and drive outcomes. And so if I'm offering a service that no one's going to use, I'm wasting time and money. And so before we do something like that, is there a way that we can figure out or look at if this is going to be effective? So my project was a needs assessment. And the way that I came to this was kind of indirectly. In addition to people recommending that we have more providers and spread them out, telemedicine has also been recommended as a way to solve this access barrier. And I thought this was a really interesting idea because I think it can address this geography question that we've talked about. So as I began to explore this, I thought, I found out, the best telemedicine programs are ones that first take the time to figure out what the needs are and how effective this might be. And I also learned that many people view telemedicine favorably, and there's some good information about that. But at the same time, opinions vary. And there was, for example, a recent study out of Montana looking at adult patients. But in that study, a high percentage of the patients were unequivocally averse to telemedicine, even though an inpatient visit was inconvenient. And so my kind of thought was, before we jump into telemedicine, let's learn what our families think about this. And so I looked at kind of a number of issues. I wanted to learn more than just about telemedicine, but what do families feel about getting that initial referral? Was it hard for them? What are the barriers to care? Is distance a problem? If so, how much of a problem? What other barriers are people experiencing? And then what do people see as an acceptable alternative? What can we do? So this is a needs assessment of patients in our clinic. So obviously we're not capturing everybody. It's only the people that are actually making it to our clinic, which is a biased population, but I think still a really good place to start. And so again, just to kind of highlight, while there may be a gap, such as poor access, and there may be a potential solution, such as telemedicine, that does not guarantee that this solution is going to work well for your population. And so a needs assessment is establishing a baseline and kind of providing a way of predicting how successful interventions might be, and that it helps in guiding next steps. So in order to make this survey, I started by reviewing the literature, looking at access to care, barriers to care, telemedicine, other types of care. Worked with some people here at the U to design the survey. That was very helpful input. And then ultimately administered this in the fall of 2015 in our clinic and had a 72% response rate. There was patients kind of from all over and all sort of demographic backgrounds. It was the parents who were answering the questions on behalf kind of their family or the patient. And most of them, again, there was a wide range of people, but primarily they were parents of adolescent patients, white, had private insurance, and the main diagnosis was JIA. So those were the most common features. About 30% drove more than 3 hours, and 5% drove more than 6 hours. So people from all over. So for me, I think it's sometimes helpful to visually see information. And so as I discuss my project, I'm going to be including a few maps, which I think kind of drive home some of the points. These maps were made using ArcGIS software, which is available through the University of Minnesota. This is a distribution of the respondents to the survey by zip code. And, as expected, based on population density, most of your people are kind of in or around the Twin Cities. And then as you get further out, there's not as many. And I think looking at information this way kind of helps me rethink the question and think about what might be effective. So for example, does it make sense to send someone to Bismarck? There's not, these people aren't really even that close. And so would it be worth it? Or would something like telemedicine make more sense in a location like that where there's people that are more spread out? So before I show you the results for my survey, I just want to point out these sorts of things that I've been doing in the maps, and that this is something anyone can do. I think it's a really cool way to look at information. There's a lot of awesome resources available through the U. There's some classes which would be free. So if this is something you are interested in looking at for your specialty or what you do, I would encourage you to get involved. There's some great people and great resources. So I'm going to go through the results or what I found, but before I show you what I found, I want to tell you what I expected. So I thought that parents would say referral was difficult. I thought they would say that distance was a big barrier to care. And I thought that those who are living further away would be interested in telemedicine. But as I started to look at the results, the story that I was seeing was a little bit different than what I expected. So I'm gonna talk about each of these sections: referral, barriers to care, and alternative care models. And I'll start by giving you the results, the numbers of what I found, and then within that, for each section, I'll kind of give you a summary or my conclusions, taking that information in context with other information that I've showed you. So for initial referral, 71% said it was somewhat or very easy. That's the red color. And only 15% said it was somewhat or very difficult, which is the blue color. Again, I like to look at this visually. The different colors here represent the different views on initial referral: easy, difficult, neutral, or don't remember. And it's less important which color is which, but to look at the fact that these colors are very spread out. So even people who lived really close said referral was difficult, or people who lived far away said, oh no, it wasn't a problem, it was easy. So I think this shows us that that kind of feeling about this does not correlate with geography. So my conclusions based on this, a couple of things. One is I think parents and providers may look at priorities differently. So parents, only 15% said that referral is difficult, whereas on that AAP information that we had looked at, in Minnesota, 36 to 49% had said it was difficult. So I recognize it's not the same question that was asked. The AAP didn't really include commentary about why people thought it was difficult. But I think it's still important to consider, maybe parents do view this differently. Maybe to them, they'll do whatever it takes to get their child care. And I think that's a possibility that we need to think about. Secondly, for parents, referral is about more than just geography. We saw that this is a little bit different, I think, than what Dr. Carell found. What she found was that providers are seeing distance as a reason to refer elsewhere. But when we look at the map, people from all over are saying different things about how easy or difficult referral was. And so parents may not be taking distance into account when they're thinking about that initial referral. And there was a section on the survey where I let people include comments, and most of them commented that if referral was difficult, it was a problem with diagnosis and not distance. There's a few people who commented on distance, but most of them did not. So in thinking about barriers to care, these are the 11 different barriers that I assessed. People rank them from 0 to 10, 0 being no difficulty, 10 being difficult enough to keep you from getting your child care. The top scores were these: child missing school with a median of 2.5, parent or caregiver missing work, and then travel time or distance, each with a median of 2. I think something else really interesting which emerged from these questions about barriers is this fact that distance from the clinic does not always correlate with whether people think it's convenient or inconvenient. So this is a map, again, looking at red is, oh no, travel was not inconvenient, and blue is, yes, it was inconvenient. And there was a trend that if you lived further away, you said it was inconvenient. But again, you can see these colors are kind of spread out, that there were people who were less than an hour away who said oh, not a problem, or excuse me, yes, it's a problem, it's inconvenient. And then there are people from very far away, more than 3 hours, that were saying, oh, it's not a big deal, it's not inconvenient. So I think what we can take away from this is distance does seem to be a barrier. That was one of the ones that people listed. I think overall it was a low what I anticipated, at a median of 2.5. So people are paying attention to it, but maybe not as much as we would think. And then there may be other major barriers which may or may not be related to distance. And so a child missing school or a parent missing work may have to do with distance, but there's also people who live very close, that they come and our appointments are long and they have to get an infusion. And so regardless of where you live, that may be a barrier. And so we need to think about that when we're thinking about how to plan our care. The other thing is that some of this is about perspective. So I showed you that map where people said, oh, it's inconvenient or not inconvenient to travel here. And that was it was variable. People had different opinions, different perspectives on what this meant. So even though it seems like geography is playing a role in what providers think and in how providers are deciding to send us patients, it doesn't always correlate with what parents think about it being convenient or inconvenient. And then the last part was about alternative care models. So I kind of asked about telemedicine separately, and then outreach clinics, adult rheumatology, and shared care together. So I'll go through each of these. For telemedicine, the question was asked as a preference. So would you prefer in-person, or would you prefer telemedicine? You can see here that 95% said they would prefer in-person, only 5% telemedicine, and this was regardless of whether or not they thought that travel was convenient or inconvenient. I asked about how familiar people were with telemedicine, whether they had used it or had family or friends who had used it, and 84% said no, only 8% said yes, they were familiar with this. And then the next thing I wanted to know is, well, if they're familiar, does that change how they answer these questions or how they view telemedicine? And we can see that familiarity with telemedicine, which is the blue color, versus unfamiliar with telemedicine, which is the red color. And we can see that those who were familiar with telemedicine here were more likely to prefer it, and that they were also more likely to view it as better or equal to in-person visits. We also looked at whether people answered these questions differently based on insurance type, travel time, other factors, and none of the other factors correlated. When we're thinking about other care models, outreach clinic, adult rheumatology, or shared care, blue is that they strongly agree. This is something they would be interested in. Red is neutral. Green is that they strongly or somewhat disagree. And you can see that people had an interest in outreach clinic at 63%, but were pretty against or disagreed with seeing an adult rheumatologist. Oh, sorry, thank you. So shared care would be like us working very closely with the primary provider or an adult provider, so they're still being seen locally, and we're kind of maybe having a conversation over the phone. Good question, thank you. So my conclusions from this, one is that, the telemedicine interest was low, which was a bit of a surprise for me, but familiarity can increase your telemedicine success. And so I think this doesn't mean don't do telemedicine. I think we can still think about that. We can still think about how it might be included in the care that we provide, but we need to know that people are hesitant and that they have some reservations about this. And we're going to be more successful if we can see those reservations up front and kind of know that going into it. Of the other kind of modalities that we explored, outreach clinics were the ones that looked most promising and interesting. I think that maybe parents and providers might have a different view about adult rheumatology care. Dr. Carell's study, as I had shown you, showed that many patients are being sent to adult providers, and one of the main reasons given for that was that patients were adolescents, and in this survey, a good chunk of the patients were adolescents, and the parents were saying, no, we still prefer to come to pediatric rheumatology. We're not really interested in adult care. Obviously it might be easier to say that once they've already started seeing us, but again, I think it's important to think, that people may view this situation differently. So, there's a lot of information. What do we make of all of this? Where do we go next? Geography does seem to be a concern for both providers and for families and patients. Exactly how much of a concern, I think, is a good question, and that may differ depending on, the provider versus parents. I think it's fair to conclude, though, that referral should be a dynamic conversation. You shouldn't just assume that it's too far, but talk to the family and get their perspective on what they think and what they think about traveling far. So earlier I talked about the fact that a needs assessment helps establish a baseline and kind of provides a way of moving forward and predicting success of an intervention. And to me, that doesn't just mean that one area has to be pursued, but maybe you can look at multiple different areas. And so it's a way of telling us how we might move forward in a way that's more meaningful than just a random shot in the dark. So just to briefly show you some of where this has taken us and what else we have been thinking about. So for telemedicine, again, my survey asked about preference. Would you prefer in-person or prefer telemedicine? Many of the models of telemedicine are a combined model where sometimes you're coming in person, sometimes you're doing telemedicine. And so I think that needs to be explored more, these different models of how we can do this. There were several people that expressed concerns that, how can you do telemedicine in a field where you're so reliant on your physical exam? And I think as we're approaching that, we need to keep an eye out for literature on this issue. There's been some studies actually already done looking at this, and for the most part, they show we don't miss big things. You might miss some little things, but the big or the important things are not missed on telemedicine. We need to think about how outcomes might be different for these different populations. So keeping an eye out for the information that's there. Kind of what we've been doing, we're kind of in this did the needs assessment, now thinking about design or where can we go next. So I attended both a local telemedicine conference as well as the American Telemedicine Association conference, kind of meeting additional people that are interested in this, learning just the logistics of how you would do something like this. We invited a guest speaker from Mercy Children's, Dr. Beth Kessler, who's doing telemedicine down there, trying to get her input on how she has been successful and what she has done. And then mHealth is in the process of actually developing a telemedicine platform, and we've been approached about the potential to pilot this in the next year, so kind of looking at that. The other thing which I think showed a lot of promise and that we have been thinking about is this idea of outreach clinics. And so for us, part of the question is, how, if we're going to do this, how can we decide where we should go, or how can we decide what would be most effective? How can we ensure that the care we're providing at these clinics is equal or as good? So there's a few different ways you can start to think about this or look at this. So I wanted to show you some additional maps, which I think can help with this process. So what I did here is I took the zip codes that I had showed you before from the people in our survey, and you make this heat map, which kind of shows you where people are at, and this could help in thinking about where it would make sense. So this here is the Twin Cities, obviously, but you see around Fargo, there's some red kind of higher intensity there. This would be Duluth. There's St. Cloud kind of over here, Brainerd. And so this, tells us, looking at Minnesota, there's a lot more hot spots than kind of the North or South Dakotas. And so using information like this could help us decide, what we might do or where we might go next. You could also look at it this way, let's map out the zip code. This is just showing mostly Minnesota, but where are people in relation to the roads or the infrastructure? How are people going to get to the places that we want to be? You could even maybe overlay this with a map of the Fairview clinics to look at, where are people in relation to the clinics that we have. And so this is just kind of a way of thinking or planning ahead. So finally, the last project that I wanted to talk to you about, I told you about Dr. Carell's study, my fellowship work, and then this is a study which I'm in the process of planning. And this gets at this question of, why does this all matter? So I've shown you the work we've done with providers, the work we've done with families, but what we don't know is how does access affect outcomes? So in order to leverage interventions which might address these issues, I think we need to gather information about why this matters. And so again, it's important to think about what information we already have around this, and I won't go into the details of that, but I'll tell you that for pediatric rheumatology, there's not much information out there about this. So this differential access to care and the potential that it could affect outcomes for kids, people discuss it a lot, but there's really no good evidence or information in the U.S. or abroad that have specifically looked at this relationship between distance from a referral center and outcomes or how a patient does. So I think examining this is the first step. and then the next step would be understanding why this is the case. So I'm in the process of planning this, which will hopefully start to answer some of these questions. This will use data from a registry that has information of patients with juvenile arthritis is the disease I'll focus on, but has information on thousands of patients from our center as well as around the country. And so what I want to do is examine this relationship between distance, does where you live affect your outcome? In addition, does where you live affect how quickly you get referred? And then, does how quickly you get referred determine your outcome? And so exploring this and results of a study like this, I think, can help us in deciding how we approach patient care. So the first step to finding solutions is understanding the problem, which we would be doing here. So we talked about at the beginning the fact that there are many factors which influence health, such as where you live or distance. And I understand that these are not always things we can easily modify, but I think still part of our job is to understand which patients are prone to worse outcomes. And our care recommendations can then include strategies which would protect these more vulnerable populations and ultimately improve outcomes for all children. So I want to wrap things up by just briefly mentioning the practical framework we have in place, which will hopefully make some of this work moving forward easier. So in order to understand the quality of care that we're providing, how our patients are doing, we have to be able to measure this. We have no way of knowing whether access matters or if these interventions that we're planning are working unless we can measure progress over time. And so in pediatric rheumatology, quality care and outcomes have been addressed through these two main organizations, CARA and PRCoin, and we've been playing a role in both of these. CARA is a little bit older. We've been involved with them from the beginning. If any of you are familiar with the Children's Oncology group, it's kind of a similar idea. It's focusing mostly on disease and optimal therapy, and it's a group of many centers from around the world. And along with kind of everyone working together, they have a registry of patients, and it has information about thousands of patients, and this is used to learn more about rheumatic diseases. CARA focuses mostly on treatment protocols for the most part and kind of what therapies are most effective, but I think the data can also be used to explore some of these access concerns that we've talked about today. And like I said, we've been involved with them from the beginning, and we're actually 6th overall in the country with the number of patients that we've enrolled in that registry that they have. PRCoin is kind of similar to GI's Improve Care Now. This organization is a little bit newer, formed in 2010, and it's really focused more on quality improvements and care processes. So it's looking at outcomes across multiple centers and then comparing what people are doing to see, what are the things that we do that lead to better outcomes, how can we learn from one another, and how can we replicate this at other places. So we're actually still in the process of joining this. It's kind of been a long time in coming, and things finally fell together for us to do this, and I'll be our site PI for this project. Again, all of our providers are involved, our nurses, our research coordinator, everyone's been involved in this, so it's an exciting time for us. I think especially when we're caring for these more rare diseases that we often see, having these collaborative networks are key to getting the information that we need. So the efforts of these two organizations could be an entire separate talk, so I'll stop there, but I wanted to point out that it's really important we have the structure and the resources to be able to accomplish some of these things that we want to. And with these two awesome organizations, I think it's a really exciting time to be a pediatric rheumatologist. So to close, I just wanted to share this quote, which comes from an AAP policy statement, and it says that pediatricians must have a second bag of tools in addition to the clinical doctor's bag that addresses the more traditional agents of childhood disease. And this second bag of tools, it includes things like partnering with public health entities, recognizing root sources of health and pathology from a child's social, economic, physical, and educational environment, advocating for children. And, I think there's a shift in this direction and a shift in healthcare. And if we don't rethink some of how we're doing care, we're going to be left behind. So today we talked about access to care. Understanding and addressing that is admittedly just one of these tools, but I think it's an important one. We reviewed the fact that access is more than just having available resources. We looked at the fact that access is at this intersection of health services and some of these other factors that are going on in people's lives. I explained kind of how I started thinking through these problems, shared some of the resources. There's a lot of tools out there. If other people want to look at these issues, it's definitely possible. I gave you some specific examples of what this has looked like for our division and kind of what we've been pursuing. I'm excited about what we're doing. I've enjoyed sharing this with you. I also recognize that the work I do is in a specific field, and everything may not be directly applicable to what you're doing. But if nothing else, I hope you can leave with kind of these 2 points. The direct care that we provide to patients is hugely important. We must, though, understand how our ability to provide this care effectively is influenced by other factors. And this sometimes requires that we adjust the structure of our care to take these other factors into account. And secondly, don't assume you know what your patients or your families want. Ask them. So I'm excited to see how this unfolds for our division. And as we move forward, I hope there will be opportunity to collaborate and learn from one another. I'm happy to serve as a resource and talk more about these issues if anyone is interested. So thank you.
Very nice talk, thank you. So to increase telemedicine access, do you envision that patients would do that from their own home, or would they have to go to, a local doctor to do that? Because, you can't even sometimes get good cell phone coverage in these areas, let alone internet.
Right. I think this planning ahead of time is really important because having the proper infrastructure is hugely important. I think at least initially it would need to be at a center, and some of that is just in order for it to be paid for. There are many insurance or Medicaid, et cetera, that would not pay for something that's done at home. And so the most likely model would be doing it at a center. And you need to identify where that could be, who has the resources. Having someone on the other end is hugely helpful that can kind of walk through the physical exam. So it's a good question.
Yeah, nice talk, Danielle. When you surveyed your patients, you surveyed people that had successfully overcome the barriers to getting to the clinic. So how do you determine the group that didn't make it to clinic? How do you understand their barriers?
Yeah, no, I think that's a great question, and it is a limit. I think a good place to start, but certainly a limit. I think if it would be possible to look at like the group in Pennsylvania, for example, that used Medicaid claims. So I think something like that that would look at everyone and look at ultimately diagnoses, because there's a lot of kids I think that are, for example, being seen by an adult rheumatologist that we never see. So we would need to look at something that captures that. It's hard because then that data doesn't necessarily include why they went there. If there was a way to survey people more broadly through maybe an organization like, say, the Arthritis Foundation that has people that are going to all these different places, that might be another option. But yeah, it's certainly a limit and something we thought about.
Great job. I'm wondering more at the national level and subspecialty workforce and resourcing, and are there national efforts within pediatric rheumatology that are trying to address some of these issues through training programs, access to subspecialty care? Because it's not just, I think, a Minnesota issue. You look at issues in, rural Montana, they can't access care. It's a national issue, and are there any efforts nationally looking at it? So
in pediatric rheumatology, there have been. One of the main guys who is involved with this is Michael Hendrickson, who is at Cincinnati Children's. He's done a lot of work and published statements about this and what he, along with others, kind of have looked at and recommend. There was also a report to Congress, which I think was published back in 2007, which looked at a lot of this data and made recommendations. And so the main recommendations they've made are exactly what you've said. So how can we, at a higher level, incentivize people to go into these subspecialties? How can we expose people to this sort of training in their medical education? People aren't going to do pediatric rheumatology if they never are exposed to it. So when there's many centers that don't have someone, how do you expose people to this? And so including curriculum changes so that people are more aware, including changes in how adult rheumatologists are trained so that they get more specific pediatric training. And then telemedicine has been one that Cincinnati has talked a lot about and was in the report to Congress. And so it's definitely something people are interested in. It's just slow going. Sometimes it takes a lot to get those resources and move forward.
Danielle, over here. Nice talk. So my question about outreach clinic versus telemedicine versus shared care, having participated in outreach clinic, I find that there is a benefit to the patients of local access, but you're lacking your resources in terms of can that child receive an infusion? Does that child have the proper coordination of care by the local group? And so I wondered how much is focused on shared care of trying to have local champions in the Fairview clinics out in Hibbing or Brainerd to say, that's the person who's going to see these people that, we are in constant communication with, either as part of telemedicine or as a separate venture rather than sending people physically.
Yeah, no, I mean, I think having that support from other people would be hugely important. First I want to comment, I don't think, for example, outreach clinic or telemedicine would necessarily be good for all patients. So I think the first step is identifying, who can that work well for, and then who do we really just need to bring here. So kind of separating out those things and understanding what those issues are. But then also identifying, like you said, the local people that can help. Infusions, for example, for us can be a huge thing that people have to come here to do that. And how can we reach out? And where should we be doing that? Where does it make the most sense? It may be challenging for us to identify someone in each and every town, but is there a way we can say, okay, what clinic or what place would be central to many of these patients, and that would be easier for them to get there, and who can we identify there? Yeah, it's kind of another next step that we should look at.
And then the outcomes at those places are dependent upon whether you can collect the data. Right.
And I think having something like CARA or PR Coin, where we're already collecting data on all of those patients, and then we can look at that and see if it differs depending on where they're seen, because you want to ensure that if they're being seen elsewhere, is that good? Are they doing as well?
Hello. I know that some of the rheumatology patients often need other specialists involved, like ophthalmologists, for example. Could the need for even more subspecialist care play into all this?
Yes.
And would it be possible to coordinate care better, I guess?
Yeah, no, I think that's another area and another way that kind of medicine is heading in general, that to provide patient-centered care, better care, it needs to be coordinated care, saving people time, money. I think with something like ophthalmology, for example, there's a little bit more flexibility. We certainly have great ophthalmologists here. There's also ophthalmologists that we've worked with in Duluth and Fargo and these other places. So maybe part of, if we're thinking about planning outreach clinics or telemedicine, those sorts of things, I think including other people in that conversation. If someone's going to a outreach clinic in Duluth, can we coordinate that with their eye visit there? Because, our kids, that's a main one, but there's other subspecialists that they see. And so I think it would be important to include those in the conversation as well. Okay, thank you guys.
You have